This is Meredith Sherman. She is a research and program assistant at our Children's National Global Health Initiative. And for those of you not familiar, this is a group of investigators and people doing advocacy work and all sorts of things on a global health level at Children's National. So she's going to talk to us about some work that's being done in the context of cerebral malaria.
Yes, so I'm Meredith. I work for the Children's National Global Health Initiative. I just want to start with that I have nothing to disclose. And thank you for the opportunity to present our research today. So I'm sure, as everyone knows, malaria is the most important parasitic disease in humans, according to the World Health Organization. In 2020, there were an estimated 241 million cases of malaria and 627,000 deaths worldwide in 85 endemic countries. Disease in sub-Saharan Africa accounts for 95% of cases and 96% of deaths, as can be seen from this graphic. 80% of these are in children under 5 years of age, and of the 5 species of malaria causing human disease, Plasmodium falciparum has the highest rate of mortality and morbidity, and is also the most prevalent in Malawi. Clinically, malarial illness is classified as uncomplicated or severe. Severe malaria is usually due to end organ dysfunction as a consequence of parasite infection. Although not the most common form of severe malaria, cerebral malaria has the highest mortality risk. Untreated, it is 100% fatal, and even with optimal treatment, approximately 16% of children will die. And a third of survivors will have neurological sequelae at discharge. So admission blood glucose is one of the earliest identified laboratory prognostic biomarkers in pediatric cerebral malaria. Although determination of blood glucose at the time of admission is the current standard of care for pediatric cerebral malaria, the optimal duration of glucose monitoring is unknown. Our goal was to evaluate the strength of association between admission and or post-admission, hypoglycemia, and adverse outcomes in children with cerebral malaria. In order to inform glucose monitoring. Our approach had 2 aims. First, we evaluated the strength of association between low glucose levels at admission and post-admission and adverse outcomes. And next, we evaluated the utility of repeat glucose measurements for clinical care and or as a prognostic biomarker. Ultimately, we determined the optimal duration of glucose monitoring in children with cerebral malaria in our cohort. So we collected data from 1,674 children hospitalized to a long-standing observational study of cerebral malaria pathogenesis at Queen Elizabeth Central Hospital in Blantyre, Malawi. It's the largest hospital in Malawi. Children were enrolled between September of 2000 and June of 2018. Our cohort included children 6 months to 14 years of age with a Blantyre coma score of under 3, Plasmodium falciparum parasitemia, and no other known coma etiology. Of these, 1,667 children had at least 1 glucose measurement and were included in our analysis. 272 children died, reflecting a 16.3% mortality rate. And of the 1,395 children who survived, 152 were discharged with neurological sequelae, so just under 11%. In our overall cohort, we had a detection of 5.4% of hypoglycemia. Patient care was managed according to guidelines from the WHO and the Malawi Ministry of Health. At the time of hospital presentation, children were clinically stabilized and immediately administered intravenous antimalarial therapy. Children with severe malnutrition were excluded from enrollment in the parent study and therefore were not included in our analysis. And finger prick samples for determination of glucose levels were collected on admission and every 6 hours afterward for 24 to 48 hours. Patients with blood glucose levels under 2.2 millimoles per liter were administered intravenous boluses of 1 milligram per kilogram of 50% dextrose, and blood sugar was reassessed. In our analysis following the WHO, we defined hypoglycemia as a blood glucose of under 2 millimoles per liter and a below treatment threshold blood sugar of under 3 millimoles per liter. So evaluating our first aim, we compared outcomes between deceased patients and survivors, and within survivors, those who returned to their neurological baseline and those who developed neurological sequelae. Due to the limited availability of glucose measurements after 24 hours in our cohort, we limited our multivariate analysis to glucose measurements taken within the first 24 hours. We found that in children with cerebral malaria, hypoglycemia at hospital presentation is independently associated with adverse outcomes, both death and neurological disability in survivors. This is congruent with previously published research. At admission, compared to normal glycemic patients, children who had hypoglycemia had a 2.87 higher odds of death, and if they survived, a 3.21 higher odds of developing neurological sequelae at discharge. At 6 hours post-admission, newly detected hypoglycemia was independently associated with a 7.27-fold greater odds of death, and neurological sequelae was not independently associated at 6 hours. At 12 hours post-admission, the number of children with newly developed hypoglycemia was too low to draw meaningful conclusions. Evaluating our second aim, the utility of repeat blood glucose measurements. In our cohort, all new episodes of hypoglycemia were detected in the first 12 hours after hospital admission. 82.3% of episodes of hypoglycemia were detected on admission, and no new episodes of hypoglycemia were detected after 12 hours. Almost 95% of new episodes of blood sugar below the treatment threshold were also occurred within 24 hours after admission. Almost 60% were detected on admission, and children who had a blood sugar level lower than the treatment threshold detected during the first 24 hours had episodes of low blood sugar up to 42 hours post-admission. This data is helping us to characterize blood glucose levels in children with cerebral malaria during the first 24 hours post-admission and can inform a more appropriate blood glucose monitoring timeline. So based on our findings, we recommend that children with cerebral malaria should have routine blood glucose measurements every 6 hours during the first 24 hours post-admission. Those with a blood sugar level below 3 millimoles per liter detected within the first 24 hours should continue to have repeat measurements of blood glucose every 6 hours for up to 48 hours post-admission. However, if children are normoglycemic during the first 24 hours post-admission, then routine monitoring of blood glucose can cease. The suggested glucose monitoring schedule will not detect up to 5.3% of children who have blood glucose levels below the treatment threshold within the first 24 hours, but it will capture all children who have hypoglycemia. So our results were recently published in the American Journal of Tropical Medicine and Hygiene, and we received an editorial highlighting our work and suggesting the potential for our data to inform updated WHO treatment guidelines for hypoglycemia in children with severe malaria. There are two major limitations to our study that are worth mentioning. First, given the nature of Queen Elizabeth Central Hospital as a referral hospital, it is possible that children who had hypoglycemia that was detected and may or may not have been treated before admission were included in our analysis. And second, due to the retrospective nature of our cohort, it was not possible to follow patients after discharge. Although mortality may occur after discharge in survivors of severe malaria and might be associated with one or more hypoglycemic episodes during admission, this was not captured in our analysis. Because neurological sequelae may either resolve or newly appear after hospitalization, it's likely more meaningful to evaluate associations between hypoglycemia and long-term neurological sequelae. In conclusion, consistent with previous studies, we found that hypoglycemia in children with cerebral malaria increased the odds of death and neurological disability. Our findings further inform an optimal blood glucose monitoring timeline and suggest that if a blood glucose less than the treatment threshold of 3 millimoles per liter is not detected in the first 24 hours post-admission, routine assessments may cease. Children who have blood sugar values below the treatment threshold detected within the first 24 hours should continue to have periodic measurements up to 48 hours post-admission. Given the retrospective nature of our cohort, prospective evaluation of the association between hypoglycemia and adverse outcomes, as well as the optimal glucose monitoring timeline would be beneficial. Continuous glucose monitoring may detect short episodes of hypoglycemia, which may or may not be clinically significant. Previous studies which utilize continuous glucose monitoring in children with cerebral malaria found rates of hypoglycemia to be double what we report here. Additionally, studies evaluating the economic and public health impact of our modified glucose monitoring protocol would provide a more holistic understanding of this proposed change to the standard of care for children with cerebral malaria, particularly for resource-limited environments where the vast majority of cases of malaria occur. I just want to say a huge thank you to our research team, particularly our research mentor, Dr. Douglas Postles of Children's National, and a huge thank you to all the clinicians in Blantyre and DC who without their significant amount of work, this study would not have been possible. So thank you.
Thank you so much for sharing that. Any questions from the audience? All right, I think we're going to wrap it up. Thank you. Well, this has been an incredible day. I just jotted down a few things that we should take with us as we leave, and maybe to our cocktail hour, or I guess we're not supposed to call it that, our celebration hour. We can call it a cocktail hour. Okay, good. So we talked about One Health approach to human and animal disease and environment. We talked about human migration and colonization, the environmental contamination and its impact on allergic and infectious diseases. We talked about the change in vectors. We talked about zoonoses and spillover into human populations. I learned a new word, syndemics. I think that's a really interesting idea, and that's come across in multiple talks today. We talked about cultural sensitivity in vaccine design and implementation, and this new concept of open platforms and sharing, not necessarily patenting things that can be life-saving across multiple parts of the world. We talked about microbiome, and I have to point it out again, the microbiome and its effect not only on infectious disease, but on allergy and immunologic diseases. We talked about we're staying too clean, and it's causing too many problems. We got to get together, get off the Zoom calls and get together and share some germs and some dirt. And then we also talked about novel mechanisms for surveillance for the next pandemic. And that's really going to pull us into tomorrow, which is really going to be a fascinating look at this new pediatric pandemic network that Children's National spearheaded and now includes 10 different centers across the whole country. So that the whole day tomorrow is going to be focused on all that great work that's being done in these first years of the Pediatric Pandemic Network. So let's go to the reception and celebrate. And I'm celebrating because last week was the first week none of our COVID tests were positive at Children's National. Thanks, everybody, and we'll see you at the reception.